Hi, everybody. My name is Adam Pick, and I'd like to welcome you to the webinar titled Advances in Tricuspid Heart Valve Surgery. If I have yet to meet you, I'm the patient who started HeartValveSurgery.com all the way back in 2006. The mission of our website is very simple. We want to educate and empower patients just like you. And this webinar, which has had registrations from over 350 patients in countries all over the world, was designed to support that mission. Now, throughout the webinar, you're going to be in what's known as listen-only mode, but I encourage you to submit your questions throughout the webinar. Now, as for the agenda, I'm going to introduce the featured speakers. We're going to have an extraordinary conversation about tricuspid valve therapy. Then there's going to be a question and answer session. And at the conclusion of the webinar, I'm going to ask you to complete a super quick 5-question survey. Now, for our panelists, I am honored and humbled that they are taking time away from their very busy practices at Penn Medicine in Philadelphia, Pennsylvania. Let's talk about who they are. Dr. Wilson Szeto is the chief of the Division of Cardiovascular Surgery at Penn Medicine. During his extraordinary career, he has performed not 1,000, not 2,000, but 5,000 cardiac procedures. He is a minimally invasive heart valve specialist. And for the topic today, he does focus on tricuspid valves. If there's one thing I tell you about Dr. Szeto, he truly is a patient advocate. And together, starting many years ago, we've created educational materials specifically to the lifetime management of heart valve disease. Now, he's not just an advocate, he's also celebrated by his patients. As you can see here, he's got a 5 out of 5 score with 318 ratings by his patients. Dr. Szeto, thanks so much for being with us today.
Adam, thank you very much. It's a pleasure and a privilege to be here. I'm really looking forward to this next hour.
Yeah, and so let's talk about the second half of the dynamic duo. This is Dr. Paul Fiorilli. He is the co-director of the Transcatheter Heart Valve Program at Penn Medicine. When you talk transcatheter, you talk valves, he definitely is a minimally invasive specialist. Similar to Dr. Szeto, he's performed thousands of cardiac procedures. And what I've learned about Dr. Fiorilli is he focuses a lot on research, and he has contributed to many publications about cardiac care. Another great thing about Dr. Fiorilli is he, like Dr. Szeto, is celebrated by his patients. As you can see here, he's got 5 out of 5 stars with 390 patient recommendations. Now, I could go on and on about the achievements of both Dr. Szeto and Dr. Fiorilli. What I'd like to do instead is show you this. These are the success stories of patients from the HeartValveSurgery.com community that have gone on to have successful heart valve therapy at Penn Medicine. Whether it's Stephen Cantor, Mark Linus, Michael Carbone, Sean Murphy, Joseph Minucci, Evelyn Healy, these patients are all living wonderful lives thanks to the dedication and commitment of Dr. Szeto, Dr. Fiorilli, and the Penn Medicine team. And with that, I would like to go ahead and officially welcome Dr. Szeto and Dr. Fiorilli to the webinar. And to get started, we're going to turn it over to Dr. Paul Fiorilli.
Adam, thank you so much. What a wonderful introduction. We are, Dr. Szeto and I, Wilson and I, are both very excited to be here with you today. We do so many things in our day-to-day life, whether that's as clinical medicine, academic medicine, teaching fellows, writing research papers, enrolling patients in trials. We do so many different things in our day-to-day, but ultimately it all comes back to the patient in front of us. And it's truly an honor to be able to be here with you today to talk about tricuspid valve disease, which is really at the forefront right now in this moment in medicine. And we're just really thankful that Adam, you asked us to do this with you and to be able to have have the opportunity to talk to so many people and go through what the options are, and hopefully help get you to the right treatments for what can help you live the life that you want to live. A little quick note on our outline today. We're going to talk about the history of the treatment of tricuspid regurgitation. We'll talk a little bit about the anatomy and physiology of the tricuspid valve. Whenever we're talking about heart valve treatment, there are really three primary categories of treatment, which is medical therapy, surgical therapy, and transcatheter therapies. The third of which really has become a treatment over the past 20 years. But we'll go through each category of how to treat the tricuspid valve. We'll talk a little bit about a patient case, and then we'll go through some overall conclusions before we get to the question and answer session, which will be great. Next slide. So in terms of the historical approach to the tricuspid valve, so we sort of historically have talked about the tricuspid valve as the forgotten valve. Now there's four valves in the heart. You hear a lot about the aortic valve, the mitral valve. Pulmonic valves you hear about in kids a little bit. That's usually congenital type issues. And the tricuspid valve was just a valve on the right side of the heart that we largely, for all of modern medicine, just ignored. It was previously thought that a leaking tricuspid valve, or what we call tricuspid regurgitation, was really just a kind of a benign thing, a long period of onset until symptoms would happen, and not really anything to worry about. And we kind of just looked the other way, more or less, for so many years, honestly, because we didn't really have good treatments for this, which we'll get to soon. We kind of focused on other valves in the heart, and there was good reason for that. So the aortic valve really has received so much concern, thought, and approach and treatment over the years, because when you have a severely tight aortic valve and symptoms, your lifespan is significantly limited from that, like very limited to a couple of years at most without treatment. And so transcatheter aortic valve replacement came around over the past 2 decades and has revolutionized that field. And as a result of that, we started with that sort of as the model and have now started to tackle each of the other valves as minimally invasively as possible. But we didn't forget completely about that tricuspid valve, and we've kind of made our way back to it. The tricuspid valve is often thought to be secondary tricuspid regurgitation to left-sided heart disease. So if you had aortic stenosis or mitral regurgitation, a leaking mitral valve, that if you corrected those lesions on the left side, the right-sided stuff would get better, and then you wouldn't have to worry about it. The bottom line, we've sort of historically ignored the tricuspid valve and neglected it. Next slide. That's a problem. So large data sets have shown us that tricuspid regurgitation, or leakiness, as we mentioned, is highly prevalent. About 15% of the population has this. In the United States, that equates to about 1.5 million people that are affected by this, with a yearly incidence of about 200,000. Severe regurgitation of that valve leads to limitations in functional status, decreased quality of life, and shorter lifespans. The bottom line here is that severe tricuspid regurgitation is not a benign condition. Next slide. The causes of tricuspid regurgitation, it's most often functional, or that means basically secondary to other diseases. And the way to think about this is when you have diseases that may cause the right ventricle or the right atrium, which sit on both sides of those valves, to get larger, it can kind of pull the annulus of the valve, or where the valve sits, it can dilate it and make it bigger and pull it apart, and then it doesn't close nicely, and it's kind of further apart, and it can leak a lot in the middle of it. And some of those diseases include things like atrial fibrillation, pulmonary hypertension, and left-sided heart disease, actually, all things that kind of cause that. Generally sort of a secondary problem, although there are a few rare causes that are primary, but generally speaking, most is secondary. In terms of outcomes, the prognosis is generally poor. Most patients are treated medically, and we'll get to what that means in a few minutes. But ultimately, what happens left untreated is this progresses to right heart failure and dysfunction, lots of lower extremity swelling in the belly, and then end organ dysfunction, oftentimes liver disease and cirrhosis from congestion of all that flow backwards to your organs in the veins. Next slide. And then Wilson, I'll turn it over to you here.
Sure. As Dr. Fiorilli has mentioned, it is the forgotten valve. In the early days of cardiac surgery, you can see here 2 decades ago, only about 5,000 cases of the tricuspid operation, isolated tricuspid operation, would perform over the span of 2004 to 2013. However, in the last 5 to 10 years, you can see that has now doubled, more than doubled, to almost 14,000 isolated tricuspid valve operations. So you can see here that the prevalence and the incidence of surgery is going up. Well, one would ask, well, why was there a hesitancy to operate in the past? Well, one, in the past, the operative mortality in that first era was relatively high, somewhere between 8 to 10% operative mortality, likely due to multiple factors. One, there was low adaptation of minimal invasive surgical technique 2 decades ago, lack of awareness of the poor prognosis of medical therapy, and finally, the high operative mortality was likely related to patient selection, meaning, as Dr. Fiorilli mentioned, we're often getting to these patients a little too late in their natural history of disease process. Fortunately, with learning and data, you can see that over the last decade, the operative mortality has almost decreased in half with a mortality rate of less than 6%. Bottom line, despite historically lower surgical rates, surgery now is becoming more common and outcomes are improving, likely due to multiple factors, including earlier intervention and minimal invasive surgical techniques. Next slide, please. As you can see here in this slide, a pictorial description of the trends and outcome. Highlighted in black at the bottom of the slide, you can see that the mortality has remained relatively stable. You can also see in blue that depicting tricuspid repair, and in red, tricuspid valve replacement, it has increased twofold over the last 2 decades. Next slide. Now, in terms of the complexity of tricuspid valve, I think this gives you a sense of what we're dealing with. The tricuspid valve is a very, very complex structure of all the 4 valves in the heart. Next slide, please. So you can see here, this is a photograph of the tricuspid valve. It is the largest valve in our body. It has the elliptical orifice. The leaflets are thin and often fragile. There are 3 leaflets, namely the septal leaflet, anterior leaflet, and the posterior leaflet. More importantly, they're adjacent to many important structures of the heart, including the conduction system or the nerves of the heart. And with leaky valve or regurgitation, these leaflets or malcoaptation is common because of the anterior, posterior, and posterior septal commissures not functioning appropriately. Next slide, please.
Dr. Szeto, if I could ask you, we've got some patients on the line who may have just been recently diagnosed with valve disease, tricuspid regurgitation, for example. You mentioned an interesting word, which was coaptation. Can you share for the patients what that means?
Great question, Adam. Coaptation refers to the ability of the leaflets of the valve to come together and coap, coming together, making sure that the valve is competent so that fluid, or blood in this case, does not go backwards. So coaptation is the leaflets coming together and causing it to be a competent valve. That's a great question.
Great, thank you.
So how do we approach tricuspid valve disease here at Penn Medicine? So the most important feature is that this is a patient-centered, multidisciplinary heart team approach that we have. And what that means is that an interventional cardiologist and a cardiac surgeon evaluate the patients together and talk through the treatment options very carefully and what those options may be, whether that's medical therapy, minimally invasive surgery, open heart surgery, commercially approved transcatheter therapies, and then also transcatheter research trial therapies if none of the above are good options. And we do that all in a patient-centered approach to figure out what option is going to be the best for that individual patient and tailored to them in the best possible way. Next slide, please. So when we get into the 3 categories of treatment, the first is medical therapy. This is the shortest of the slides for the different treatment categories because, quite frankly, for tricuspid regurgitation, we don't have a lot of options. The tried and true option of medical therapy for TR is diuretic therapy, essentially what we call quote unquote water pills. It helps with symptomatic improvement and helps folks to relieve some of the symptoms of fluid retention by peeing the fluid out. This can be limited by renal function. And actually, many patients who have tricuspid regurgitation also have kidney disease. And sometimes diuretics may not work as well or can affect kidney function, in which case it can limit your ability to treat. There are other classes of heart failure medications which can be tried. And on the left side of the heart, we have several classes of drugs for heart failure that we can use. But the impact of these medications on functional improvement, the right ventricular remodeling, none of this has really been well validated. So the bottom line here is that we have limited medical therapy options for tricuspid regurgitation. Next slide, please.
Now, in terms of surgery, your traditional surgery for tricuspid regurgitation, we've made significant strides over the last 2 decades, hence the decrease in mortality over the last 2 decades. Next slide, please, Adam. With the advent of minimal invasive tricuspid valve surgery, either using endoscopy or endoscopic instruments or robotics, instead of a sternotomy or quote unquote cutting your chest open, many of these operations today can be done through a little incision on the right side of the chest, as you can see here in this picture. A very small incision, less invasive approach. And I would think that that's one of the major reasons why the outcomes has improved. Next slide, please.
Dr. Szeto, real quick, comparison between this approach and sternotomy, it looks as if almost there's no breaking of any bone in this approach. Is that right? Are you spreading the ribs, or is there any fracture to the bone during this process?
Adam, that's a great question. The answer to your question is yes. There's no breaking of bones. You can see here on this picture that the access to the heart is in between your ribs. And this avoids cutting bone or breaking bone in many instances. And as you can imagine, quicker recovery, less pain, and importantly, better cosmesis. But that's a great question, Adam.
Great, thank you.
Now, as surgeons, we also wanted to make sure that if we were to proceed with minimal invasive surgery, that the surgical technique and outcomes cannot be compromised. That is a key tenet of minimal invasive surgery. And we can do that. Even though we do it through a smaller incision or with the use of a robot, it does not compromise our surgical techniques. And in many ways, it improves the outcome. When it comes to tricuspid valve repair, or what we call annuloplasty, it means that using sutures, we're then able to put a band, as you can see here on the top right-hand side of your slide, and suture them to the annulus, which is the rim around the valve. So it's called annuloplasty. And oftentimes by quote unquote tightening the annulus, you can downsize the annulus and repair and basically get rid of your leaky valve. So that's a very common technique we do when it comes to tricuspid valve repair. Next slide, please. Now, excuse me. Now, if the leaflets are damaged, or if the surgeon feels that the leaflets are not repairable, excuse me, folks, I have a cold. I apologize. The replacement platform is something else we can also do through the same minimal invasive platform. So a smaller incision does not compromise the repair or replacement. And in this case, a valve, as you can see here, a bioprosthetic valve, or what we call a tissue valve, can then be sewn into the tricuspid annulus. And then you have now essentially replace the tricuspid valve. Next slide, please. Recently, just a little bit of data here to share, the Society of Thoracic Surgeons, or STS, which is our largest professional society in North America of thoracic surgeons or cardiothoracic surgeons, have recognized the need for better outcome and metrics of how we do surgery. And this is a newly created risks model for surgeons to be able to tell the patient when I see you in the office what the risk of the surgery would be. And this is all based out of 5 million patients in our database, into adult cardiac surgical database of the STS. So this is another tool that surgeons are able to use to help inform patients and make better decision about what's the best therapy. Next slide, please.
So that's the surgical treatment for tricuspid regurgitation. As Dr. Szeto just really nicely went through, this is increasing in and becoming less invasive. So more operations offered, better risk assessment with what was just shown with the STS risk score, and becoming less and less invasive on the surgical side. And that brings us to the third category of treatment for valve disease, which is the transcatheter therapies for tricuspid regurgitation. Next slide, please. So, and you can advance that. And one more, thanks. So, and one more actually. So this, I love this. The future is now. And so this is an editorial that was published about 13 years ago now at the dawn of TAVR, which is transcatheter aortic valve replacement, which again, as I mentioned earlier, is sort of the model for transcatheter therapies. And this is, I love this editorial. It said, time for a compensatory pause. And if you look this up and read this editorial, it basically says, oh, there's all this new technology for transcatheter aortic valve replacement. Maybe we should pump the brakes. Maybe we're too ahead of ourselves. Maybe this isn't all going to work. And then cut to, 13 years later, and TAVR has completely changed the paradigm of treatment of aortic stenosis. Now, there were issues early on in the TAVR experience, and Dr. Szeto can tell you, some of these experiences in very early stages of what's called the partner trial for transcatheter aortic valve replacement, where there were issues and complications that happened with the devices, and they were big and bulky and all different types of things. And all of that got better. That's what led to editorials like this. But the technology got better. It continued to evolve. It still is evolving in that space. And the early issues associated with TAVR had engineering solutions. And what we've learned as a medical community is we should keep pushing the envelope further and keep improving and iterating and making these treatments better and more accessible to patients and fix the problems with engineering solutions. Next slide, please. The year 2024 was truly an inflection point for the treatment of tricuspid valve disease. And I'm going to get into that in a second. Next slide, please. And this is an important time. If you have this problem, this is almost the right time in modern history to have it. In February to April of 2024, were truly an inflection point for the treatment of tricuspid valve disease. February 1st of last year, the Edwards Evoque transcatheter tricuspid valve replacement, a full catheter base, and Adam's showing you there on the bottom left, a full valve replacement delivered via femoral vein, transcatheter-wise, without any cutting at all, received FDA approval February 1st of last year. Later that month, there was an FDA panel for the Abbott tricuspid clip, or TriClip as that's called, similar to MitraClip some may have heard of on the other side of the heart. And that's showing you in the top panel there. This went to a full FDA panel in February and was FDA approved on April 2nd. We're going to talk about the trials that got those approved and what this entails. Next slide, please. There's sort of three big key transcatheter tricuspid valve trials that have happened and come to fruition, the third of which is still ongoing. The first is the TriLuminate trial, which was a trial of Abbott's TriClip or tricuspid clip, which you can see right there at the top of the screen. The second trial we're going to talk about is the TriSend trial, which is the trial of the Edwards Evoque valve, full transcatheter tricuspid valve replacement. Both of those trials came out over the past year. And then the bottom right here is the CLASP II TR trial, which is made by Edwards Life Sciences as well, which is basically something called a clasp, but essentially a tricuspid valve clip is the same concept. Similar in concept to the Abbott TriClip in terms of mechanism, or what we call edge-to-edge repair, meaning the edge of the leaflets that we're going to repair them and bring them together. Next slide, please. This is the TriLuminate trial. Again, this is Abbott's trial of the tricuspid clip, which you can see here. We enrolled patients in this trial with symptomatic severe tricuspid regurgitation. That's actually true of all of these trials. This is a randomized trial. Patients were randomized in one-to-one fashion to tricuspid valve edge-to-edge repair, or TEER as we call that, with the TriClip system, that's the clip here, versus medical therapy. And like we talked about earlier, medical therapy is essentially just diuretic therapy. We had a composite endpoint here that included things like death, tricuspid valve surgery, hospitalizations for heart failure, and then improvement in quality of life at 1 year. Next slide.
And Dr. Fiorilli, a quick question for you. For patients who may not
Sure.
understand the nature of a randomized clinical trial, when you
Yeah.
say one-to-one, can you explain what that means? So you and your team and all of the researchers are trying to get a understanding of how these therapies compare in a randomized setting?
That's exactly right. Great question. So, in patients that meet criteria, meaning they had symptomatic severe tricuspid regurgitation, standard of care would be medical therapy with diuretics. And we took patients like this. These are patients who are at high risk for open heart surgery. So, where we were not thinking about open heart surgery. And we would randomize them to treatment with the clip versus treatment just with diuretics. And it's a direct comparison to see if treatment with the clip is better than treatment with just the standard of care diuretic therapy. And it's sort of a standard of how we do device trials in the United States.
Great. And one quick follow-up. I remember for the TAVR partner trials,
Yeah.
there was a indication that started at the inoperable setting for patients and then worked its way down to risk. Is that happening here with these trials, or how is risk playing into an FDA approval?
That is a really, truly great question. Yes, that is absolutely true of the TAVR world and aortic stenosis literature. Not so much on the tricuspid side. And as Dr. Szeto showed you the data, patients for isolated tricuspid valve surgery, the mortality rates are sort of anywhere in the 5 to 8%, which is generally considered high risk. So by definition, almost every patient sort of considered at higher risk for surgery, maybe not prohibitive risk, but higher risk. And as a result, we haven't randomized against surgery and have kept it, against medical therapy. And I don't anticipate there will be trials to assess against the two going forward.
Very
Most of these
interesting.
patients just were not treated, unfortunately. Yeah.
Very, very interesting. Thank you.
Yeah. So these are the results of the TRILUMINATE trial. There were 350 patients enrolled, 175 in each group, average age 78. The primary endpoint did favor the TriClip group, the group that got the intervention. It was statistically significant. Important to note, there really were no differences in death, tricuspid valve surgery, or heart failure hospitalizations. The big difference was in quality of life improvement. So what you're seeing in this chart here on the left is in patients that were achieved moderate or less regurgitation from severe, massive, or torrential. If you got a reduction in the tricuspid regurgitation, which almost every patient did, you had a significant improvement in your quality of life scores. And then what the graph on the right shows is it's just based on the grade reduction of the tricuspid regurgitation. The more you reduce it, the better the patients feel. This is a quality of life, significant quality of life improvement. And what I didn't show you here is that this device is very safe. So based on the safety and the quality of life improvements, it was approved by the FDA for this indication. Next slide, please. Next is the TRISCEND trial. This is the randomized trial of the Edwards Evoque valve, the full valve replacement, versus optimal medical therapy, again, diuretics, in patients with symptomatic severe tricuspid regurgitation. Primary endpoint here was improvement in the leakiness, quality of life improvements, and rate of major adverse events at 30 days. Next slide, please. So I'm going to tell you a little bit about the story of these results because it's important in terms of how things progressed. We did not get the full results of this trial before the FDA approval, which is quite unusual. We got the FDA approval based on the first 150 of the 400 patients. And this is what you see here. This is what it was approved on by the FDA just about a year ago, almost to the day. It was successfully implanted in almost every patient, 95.8%, and the primary endpoint was met. Excellent TR reduction at 6 months. The full valve replacement reduces the leakiness of the valve almost to nothing, whereas the clip reduces it more moderately so. And there was superior quality of life and functional outcomes at 6 months. And that's what you're seeing in this graph at the top right. The blue bar are patients that got the valve replacement. Gray is a control group just with diuretics. And then you're just looking at 3 different quality of life improvements. One is what's called on the right is called a 6-minute walk test, how far patients can walk in 6 minutes. And all of these favored the Evoque valve. What's in the bottom right is why it got FDA approved before the full results came out. And what you can see, the blue bar, it's a little hard to see that, but the point of this is that the blue bar here, as you get all the way over to the right, this is a mortality curve. The blue bar favors a decreased mortality when you look out to 2 years compared to just medical therapy. And so there's a trend towards improvement in mortality. And the FDA looked at this and thought that this was really important here. Next slide, please. And this led to the FDA approval, which is for patients with symptomatic severe tricuspid regurgitation despite optimal medical therapy. Next slide, please. We then got the full results in the fall, and the full results were equally as encouraging and reassuring. A total of 392 patients were enrolled, and this was 2-to-1 randomization, meaning that for every 3 patients entered into the trial, 2 got the valve, 1 got medical therapy alone. And so 259 had the valve. The average age of patients similar to the Triluminate trial, 79.2. And interestingly, 75.5% were women. That's a little unusual for an interventional cardiology and cardiac surgery trial, where usually most, especially in the aortic valve trials, TAVR trials, most were men, actually. So this is a really kind of a cool nuance of this trial as well. At 1 year, 64.6% of patients in the EVOQUE group were considered, quote unquote, alive and well, versus 31% in the medical therapy group here. And it's basically disease-specific health status. If you look at that over the course of the year, it starts to separate here. The blue bar is the EVOQUE valve, and the green bar is just medical therapy. It gets better at 1 month, and that's sustained out to a year. Next slide, please. So the conclusions from this trial were that for patients with severe tricuspid regurgitation, a transcatheter valve replacement was superior to medical therapy alone for the primary outcome. This was primarily driven by improvements in quality of life. These benefits start at a month, continue, increase to 6 months, and remain durable through at least the first year. And just as a point, we don't have the longer-term follow-up yet, but we do anticipate that these results will be durable. Next slide, please. Lastly, on the trial side of things, I wanted to just mention the CLASP II TR trial, which is an ongoing trial of 825 patients randomized to medical therapy versus the Pascal device, which is an edge-to-edge repair, similar to the tricuspid clip for patients with symptomatic severe tricuspid regurgitation. Next slide, I'm sorry. And so those are the trials. The CLASP II TR is ongoing, and we're in the process of enrolling patients still in that right now. I wanted to share a little bit with you about our tricuspid valve experience here at Penn Medicine. We are a high-volume, minimally invasive surgical program. We are extensively involved with transcatheter tricuspid valve research trials, including all 3 of the trials that we just mentioned. We were high enrollers in the TRISCEND trial, that was the Edwards EVOQUE tricuspid valve replacement. And we implanted the first commercially approved transcatheter tricuspid valve replacement in the greater Philadelphia area, actually in the entire state of Pennsylvania. And this is that first patient. And we have maintained a high volume nationally for transcatheter tricuspid valve replacement. This patient, I'm going to tell you a little story because something happened today somewhat unexpectedly as I was preparing for this that I thought was really kind of, I just wanted to share with the group. So this is the first patient we treated commercially with the EVOQUE valve, the transcatheter tricuspid valve replacement. And she had been struggling for a very long time in and out of the hospital with swelling on her legs, swelling in her abdomen, requiring IV intravenous diuretic therapy. And we brought her down to our hospital after they kind of had, she had been recommended for hospice at another facility. And she was in with us on and off for several months, actually, as we were taking fluid off of her, and also in the process of getting the EVOQUE valve on the shelf. With research, things take time, and then to get it commercially approved, there's hurdles you got to get through, and payment, all this kind of stuff to get the valves on the shelf. And she hung in there, and every day I rounded on her for months and got to know her and her family extremely well. And she was our first patient, and she did well for a period of time, but had some ups and downs. And she ultimately ended up passing away about just a couple of weeks ago. And I talked to her husband for a while afterwards, and was really thankful that she had kind of gone the distance with us here and was the first one to kind of go that walk with us. And today, when I got into my office after a long day in the cath lab, as I was just getting ready to sign on to this, I had got something in the mail from her daughter. This literally came today. So I couldn't make this up if I tried. And I just wanted to share a little passage with you that I thought would be helpful. And so when she passed away, I was quite upset and disappointed. And this is from her daughter, and this is directly from her. She said, "I'm writing to tell you to not give up. Continue to push the boundaries of medicine as we know it today. The work you are doing is beyond important. I'll never forget the day we were at our local hospital after they sent her to the ICU, and the cardiologist came in and started talking about palliative care. They didn't know how else to treat her. I called your office, and by that afternoon, we were transferring her to Penn, because we knew we had more you could try. You weren't ready to give up. You gave her more than a year. Yes, she had many hospital stays, but we made new memories. She got several months at home where she felt like herself again, and she spent one day teaching me and my brother how to make halupkis, which I had to look up as stuffed cabbage. She saw her granddaughter turn 6, and she was there for her birthday party. And in the final months, she had almost 2 weeks of quality time where she could still get out of bed, visit, and talk, and eat good food, not heart healthy food. She got to see her son get married. I'm convinced the valve surgery was worth it. Those final weeks at home were a true gift. And so I just wanted to share that with you. Really quite a touching experience, and been one of the most powerful experiences in my career up to this point. We'll go to the next slide here. This is another patient case. This is a patient Dr. Szeto and I treated just about, I don't know, maybe a month and a half ago, 2 months ago, or actually a couple months ago. This is an 89-year-old gentleman. He's a retired urologist with symptomatic severe tricuspid regurgitation. He's actually a retired urologist on our faculty here at Penn. And these are his words. In April 2023, I returned from a trip to Tucson, Arizona, with significant swelling of both lower legs. As a retired physician, I realized something was wrong. I saw my geriatrician, who diagnosed heart failure and referred me to Penn Cardiology. After some additional tests, my diagnosis was right heart failure related to tricuspid valve leakage. I then learned that Penn Cardiology was involved in testing a new valve replacement, tricuspid valve replacement, that was inserted via catheters through the veins of the leg. With my cardiologist, Dr. Fiorilli, I scheduled a procedure. I was admitted to the Penn Hospital, and the valve was inserted under anesthesia by Dr. Fiorilli, Dr. Herman, and Dr. Szeto. Next slide, please. This is his echocardiogram, and what you can see in the panel on the left here is that flow going downwards that Adam's showing you is the leaking tricuspid valve, the valve sort of in the middle there. And you can see that on both sides here. In the view on the right side, it's a transesophageal echo. The flow is actually going the other way, is going up there. And so that's all leakiness of that tricuspid valve, or what we consider severe tricuspid regurgitation. Next slide, please. And this is the procedure. We're up from the femoral vein, in the right femoral vein, and we have the device across the tricuspid valve. Trust me, that's where it is. And then we have a transesophageal echo probe in that's visualizing what we're doing. And then we open the valve up slowly, curl it underneath the leaflets of the native tricuspid valve, and open it up. And that's what it looks like when it's fully deployed. And these are fluoroscopy images. Next slide, please. And this is the post-procedure echocardiogram. So in this view, this is a transesophageal echo. So the abnormal flow we were seeing previously was flow going upwards from here. And as you can see, all the flow is going downwards. So there is actually no regurgitation after the valve replacement here. And what you're seeing in the middle of the screen there is the valve. Next slide, please. And how did he do? So these are his words again. Quote unquote, the next day I had minimal discomfort in my groin area. I was discharged 2 days later. My recovery since then has been without any problems, and subsequent tests show that my new valve is working properly. We have a 5-story house. Before the new valve insertion, I was breathing heavily after 1 flight of stairs. Now I can do 2 flights without trouble. Dr. George Stratch. So those are just a couple of patient experiences that we've seen here anecdotally at Penn Medicine with tricuspid valve treatment. So in conclusion to the session, and then we'll get into the question and answer period, the tricuspid valve has historically been untreated. Symptomatic severe tricuspid regurgitation has long-term consequences, and medical therapy for tricuspid regurgitation is actually quite limited. Surgical therapy for tricuspid regurgitation is much less common, but is increasing, and surgical techniques are improving and becoming less invasive. The field of transcatheter tricuspid valve therapies is rapidly developing and evolving, as you're seeing in real time. Next slide. The tricuspid clip with the TriClip system is safe and leads to improvements in quality of life. The transcatheter tricuspid valve replacement with the Edwards Evoque valve is safe and leads to significant reduction in tricuspid regurgitation and significant improvements in quality of life. But much more investigation is needed to understand which patients will derive the most benefit, which device strategy to use, and the timing of when to intervene. And with that, I will stop talking. We'd love to take your questions, and thank you again for your time as we've had the chance to share these really exciting developments with you.
Yeah, well, Dr. Szeto and Dr. Fiorilli, I can't thank you enough on behalf of your former patients, your current patients, your future patients, and all the folks on the line who are going to be watching this webinar, whether it's today or as we put together a video in the future. There's a saying in the Pick family house of being TMI'd, which means touched, moved, and inspired. And hearing those patient stories, I can tell you, you too have TMI'd me with your research, your commitment, your dedication to advancing this field, which, as you noted, this valve has been the forgotten valve. And so I only hope we can raise awareness and continue to help these patients who now it seems like we have some pretty good devices and therapies to help them. To shift gears, let's get to the questions and answers that have come in for you, Dr. Szeto and Dr. Fiorilli. The first one is a very interesting one about tricuspid valve disease and its association with mitral valve disease. This comes in from Dean, and he asks, "Hi, Adam, why are the tricuspid valve and mitral valve so intricately linked? That is, if the mitral valve is malfunctioning, it can impact the ability of the tricuspid valve to function." Thoughts?
Sure. Yeah. So I'll comment quickly. There's a couple of ways that they're interlinked. They both share space in the heart. And Dr. Szeto could comment more on that. They are both close to the septum of the heart, they're sort of interconnected from that standpoint. But they're also connected sort of in series. So if the mitral valve is leaking on the left side of the heart, it backs blood up to the lungs, and the blood pressure in the lungs can go up. When the blood pressure in the lungs goes up, it increases the back pressure to the right side of the heart. Blood pressure in the pulmonary artery, which goes from the right side of the heart to the lungs, gets higher, and then that can lead to leakiness of the tricuspid valve because there's so much pressure it's pushing against. So they're sort of anatomically linked, but also linked pressure in series as well. So one often leads to the other. And actually is one principle we often think about in terms of treatment from a transcatheter standpoint is we often work our way down from left to right in terms of treatment of valves, because oftentimes you may see an improvement in one valve that's upstream after you fix the downstream valve. Although that's not 100%, that's definitely something we think about.
Great. Moving over to, this is a double patient question from Barbara Maureen. It's all about concomitant surgery of that association that you just talked about, Dr. Fiorilli. Let's start with the first one. How often and why do patients need both tricuspid and mitral valve surgery? What if the tricuspid valve is just mildly leaking?
Yes, Adam, thank you for that question. That's a wonderful question. And the incidence of concomitant or simultaneous surgery to address both the mitral and the tricuspid valve, it's going up. And that's likely due to a combination of awareness and improved surgical techniques and outcome. So that number, it is going up. Now, if the tricuspid valve is only mildly leaking, there's certainly data to suggest that perhaps by fixing the mitral valve alone, that the tricuspid mild leak would improve. However, if the tricuspid valve leak is at least moderate or greater, we have known now for over the last decade that a more aggressive approach, meaning not ignoring the tricuspid valve, has resulted in better long-term outcome for patients. So that being said, if you have at least moderate tricuspid regurgitation at the time of mitral valve surgery, we as surgeons now will tend to address both.
Great. And so let's continue on with the question of, does tricuspid valve disease ever just go away by itself after isolated mitral valve repair? Are there better outcomes if it's fixed?
The answer is it can, depending on the scenario and the mechanism of why the tricuspid valve is leaking. Similar to the first question, if the tricuspid valve leak is relatively mild, oftentimes addressing the mitral valve would address the tricuspid valve disease, and oftentimes it will get better. To what Dr. Fiorilli mentioned earlier about the mechanism of tricuspid valve leak, if it is a structural issue, meaning there's a perforated leaflet or it has been damaged by a pacemaker lead, oftentimes that will not get better with mitral valve surgery. And the surgeon would then be more aggressive in addressing both of those at the time of surgery.
Great. And this is a question I'll offer it up to both of you because on the surgical side, Dr. Szeto, the question is, what are the risks and benefits of pacemakers for tricuspid valve repair patients? And for Dr. Fiorilli, we know that the rate of pacemaker implant for something like TAVR is, I think, more common. Does that apply for these new devices like the Evoque?
I will take the third bullet and I'll let Dr. Fiorilli address the fourth. In terms of the tricuspid valve repair or replacement, obviously we know what the benefit is. The idea is to make the valve not leak and make you feel better. The risk, one of the major risks of tricuspid valve surgery is interruption of your rhythm, meaning the heartbeat, because of where the conduction system sits, which is right near the tricuspid valve. A suture could pinch the nerve to the heart and cause heart block, thereby requiring the surgeon to need a pacemaker. So that is one of the more common potential risks of a tricuspid valve surgery.
Yeah, and it's an issue with transcatheter tricuspid approaches as well for same reason. For the edge-to-edge repair technology, the clip, less of an issue because you're not going as close to the annulus of the valve or the outer part of the valve which is closer to where the electrical wires are running essentially. And with the Evoque valve, the full valve replacement, that you saw that big cage on the fluoroscopy image, that does invoke that problem. And so it's about a quarter of patients, 20-25% of patients with the Evoque valve replacement will require needing a pacemaker afterwards. But what's also been nice is our engineering on the pacemaker side has gotten really good too. So we have a nice strategy here at Penn that we're figuring this all out in real time. But we're putting a lead in what's called the coronary sinus. Our electrophysiologists are. So it's not across the tricuspid valve. So in patients that develop heart block after the valve goes in, we're not putting a new lead across that fresh tricuspid valve. We're putting it sort of around the where the wires go in what's called the coronary sinus and avoiding that issue, which has been a nice kind of development. Again, we're kind of working together in real time to solve these problems.
Yeah, that's fantastic. I did not know that. And you, Dr. Szeto, you addressed the fourth point already. So let's move on to Samantha's question. This is just a great question about the lifetime management of valve disease. Many patients in our community, we're living longer lives. So we might have a first procedure and 10, 15 years, we may need another one. Let's talk about that with the advent of some of these newer devices. Samantha asks, hi, Adam, I'm in Australia and have radiation-induced valvular disease and underwent a triple valve replacement 5 years ago at age 44. 2 mechanical valves in the mitral and aortic position and 1 tissue for the tricuspid. I will need to replace the tricuspid valve at some point in the next 5 to 15 years. My question is, what are the current outcomes for transcatheter tricuspid valve replacement in cases where the valve has been replaced before? And can it be replaced a third time? Does the fact that the other 2 valves have also been replaced make a difference too?
This is a great question. And so, and this is actually something we didn't show specifically in this talk, but one of the lessons we've learned from the TAVR experience is sometimes you can take something that's suited for one area and use it somewhere else. And so what we know is if you have a full bioprosthetic surgical valve or biological surgical valve, that you can just land a TAVR valve inside of it. So we take the Edwards sapien valve and we often put it inside of other surgical valves. And so in the aortic position, we call that an aortic valve and valve. If there's a prior bioprosthetic aortic valve, we'll put a transcatheter valve inside of it. But we also do this in the mitral position and also the tricuspid position. And we have done certainly tricuspid valve in-valve replacements using the commercially available Edwards sapien valve, which has been around for a decade or longer in the current form. And you put it right inside and land it inside of the valve that's there. It's actually, from a technical standpoint, it's relatively straightforward because there's a landing zone to put it in. Can you put a third one in there? And the answer is yes, you can. You're decreasing your area the further you get into that, but that is doable. And there may be options as we go forward. Again, like I talked about in that slide about TAVR, is that the early issues were solved with engineering solutions. And that's only going to continue as we move forward. So one option, there may be an option to take the leaflets out of that valve in the future and put a new valve inside so you don't keep shrinking the size of the valve. All things that are likely coming by the time you would need that, Samantha. And I think that there's some really good options ahead for you. The fact that the other two valves have been replaced don't make a huge difference in terms of the treatment of the tricuspid valve, in so much as mechanical valves generally last extensively long amounts of time. And so those just won't be problems for you going forward. And we can focus just on the isolated tricuspid valve.
Yeah, and just a real quick follow-up. And Dr. Szeto, you helped me understand the value of just getting that first procedure right. In particular, if you do need some kind of surgical aortic valve, I think you helped me understand it's about getting the largest valve possible. Does that still apply here in the tricuspid scenario?
Yes and no. I think, and that's a great question, Adam, because the tricuspid valve in itself, it's a larger orifice. The likelihood that you can put a bigger valve in with less challenges than an aortic valve is there. But you're absolutely right. If we're going to be putting in transcatheter valves inside a surgical valve, it would benefit the patient most if you start off with the largest biologic or prosthetic valve as possible to allow for future multiple catheter-based intervention.
Fantastic. And getting to Mayuki's question, I received this about 10 minutes before we got going on the webinar. She's asking about the criteria for surgical versus transcatheter approaches. She asks, my question is, what determines if you are a good candidate or not for a minimally invasive tricuspid valve surgery?
Looks like Dr. Zeto's having a little cough there. I'll jump in first. So yeah, this is a great question, and this is what we talk about in the office with patients pretty routinely. You know, it comes down to a lot of different factors, and a lot of those are individual to each individual patient. What we call quote unquote comorbidities or other medical conditions that you may have. One of the things that often tracks with a leaky tricuspid valve over time is that you can get a lot of back pressure to the liver and have some liver disease associated with it, which generally makes surgery much higher risk. And so there are some factors from that standpoint, some kidney disease factors that may also play into it. And in addition to that, just overall patient preference and factors. Generally speaking, as you saw in these tricuspid valve trials, most patients were close to 80 at that point, which also, that's when we often see these diseases is later in life. And that also plays into surgical risk versus minimally invasive catheter-based risk as well.
And I think that's why this team approach to patient care is so important to us. We think it really is the way to go. Every patient is evaluated by a surgeon and a cardiologist to come up with a plan that's best suited and tailored to that one patient. And it's based on age, comorbidities, anatomy, you know, whether a patient's anatomy is amendable to a catheter-based approach. All of that get discussed in a team approach environment, and we allow the patient to make the best and most informed decision.
And I've got a follow up for Mayuki here. If she goes and she has a consult with a heart valve team and hears, no, minimally invasive is not appropriate for you, but she wants to learn more, would you encourage her and all the patients on the line to maybe get a second opinion to learn if there are other approaches that may just not be the specialty of that first cardiac center?
I would. I think that's always the right move to get a second opinion. And if you ask your doctor about a second opinion, they say don't do it. That's usually not a good sign. So I think it's really important. And the other reason why I'll say that is these not all of this is available everywhere right now. Especially I'll speak to the transcatheter side. I know the minimally invasive side, as Dr. Szeto was talking about, not everybody specializes in that at all. But from the transcatheter side of the equation, this requires careful guidance with a transesophageal echocardiogram, and that's really a critical piece of the procedure. And not every place has the availability of that the way larger centers might, and things along those lines. Now, and this is the same thing that happened with the story with TAVR. It started only at selected centers and then now is much more widely available. I anticipate the same thing's going to happen with tricuspid valve therapies, but that's going to take time. And so if you're not being offered the things that are available, that's a question to ask as to why, and maybe seek other thoughts and opinions and things like that.
Fantastic. And getting to something that is widespread in our community, it's AFib. When
Yeah.
we do surveys of our patients, about 24% of our patients have some form of struggle with atrial fibrillation. Bruce asks, I've got a leaking tricuspid and mitral valve plus AFib. While I would prefer to avoid a sternotomy, I'm curious to know what my options are for less invasive approaches to handle this. Is it possible to be clipped on two valves and then get a Watchman?
The answer is yes, but it really is patient dependent, and certainly getting back to that multidisciplinary approach that Dr. Szeto and I were just talking about. It really depends on your specific anatomy, what your risk factors look like, et cetera, and what needs to be treated, and the timing of all of the above. The truth is, in patients with tricuspid regurgitation, for example, what I didn't show is in the TRISCEND trial, 95% of those patients had atrial fibrillation, which was stunning. When I read that, I didn't believe it. And I mentioned it to one of my colleagues here who said, no, that can't be right, and told me that was definitely wrong. Well, so it was how it just, I'm like, no, it actually, I went back to the paper. I couldn't believe it. And so it's an important feature here. And so thinking about how to approach all of these things is critical. And so Watchman is an option. Watchman decreases stroke risk and atrial fibrillation, and allows folks to sometimes come off blood thinners. That's separate from our discussion here, but it is often reasonable to consider percutaneous treatment options. But sometimes the surgical approach is the best way to go, where you fix everything all at once, including the AFib, and get rid of the left atrial appendage. And Wilson does that quite a bit as well. So it really depends on individual factors.
Exactly. And I think certainly a transcatheter approach is very reasonable. To Bruce, I'm also happy to inform you that if you're not a candidate for transcatheter approaches, a minimal invasive robotic or right thoracotomy surgery could also be performed with concomitant ablation. So we can do that too. We can oversew or clip the left atrial appendage and do an ablation at the time of a minimal invasive surgical mitral valve and tricuspid repair. So those are all options, and I think that's why it's so important for a patient to go to a team approach, a multidisciplinary heart valve clinic to get the best answer and the most informed decision.
Fantastic. And let's talk about a question I'm going to ask both of you, because this is my question for today, which is, we've talked today so much about the different options that are available to patients. And when I look at the evolution of this specific industry in healthcare, it really feels like there's just it's a golden age, because there's so many possibilities today. Obviously, safety is paramount to everything that you at Penn Medicine do. But the flip side is, with all that opportunity and possibility, it can be very confusing for patients. So I remember when I was going through this, and this was 19 years ago, I was confused, and that was before all the transcatheter devices were available. So what is your number one piece of advice for patients on this webinar?
Yeah, Wilson, I can take that first. So my number one piece of advice is the following. Have yourself evaluated in a place that takes a full multidisciplinary approach, patient-centered, to your care. And the reason for that, and what I mean by that, is you're going to hear all of the options from both sides, from an interventional cardiologist, a cardiac surgeon. Even if they don't see it together, you can see them independently and have the discussions together to know what is the best option for you individually. When I see patients together with Wilson or with some of our other surgeons here as well, I learn something from those interactions every time when they're talking about the surgical approach. I certainly talk on the transcatheter side of things, and then we do a lot of that work together. And having that approach, you'll hear all the options in a way that sort of fits you as an individual person to achieve your individual goals. And so that'd be my biggest piece of advice.
Yeah, Adam, I would echo those comments by Paul, and I would make the second point, which we've already alluded to. Do your research, be aware, take your time. It is an important decision. Second, third, sometimes fourth opinions is not uncommon. take your time to find a physician or the team that you're most comfortable with. Physicians that you want taking care of, that you want to take care of you, will not be offended by that. I just want to say that Paul and I would be completely more than happy to see multiple opinions. We do not take offense to that. It is not wasting anybody's time.
Well, that is great, empowering advice, Dr. Szeto and Dr. Fiorilli. And what I'd like to do now as we wrap up the webinar, but please don't hang up just yet. I'm going to ask you to complete a survey real quickly, but I just want to take some time and thank you for delivering all of this excellent information. I know I learned a lot today. I imagine all the folks on the line learned as well. And then to the people in our community, thanks so much for being here together. Together, we are definitely having an impact on our own healthcare and making some really important decisions that can only help us down the road. And now I will go ahead and say thanks for your survey. We're going to wrap this webinar up. And when I turn the webinar off, you're going to see a 5-question survey appear on your screen. So once again, Dr. Szeto, thanks so much. Dr. Fiorilli, thanks for being with me. And thanks to all the members in our community. And as we always say here, keep on ticking. Thanks for being here today.